So as usually, we'll start with hearing some updates from Sarah Peterson, Director of Office of Refugee and Immigrant Assistance, Washington State Refugee Coordinator, and our main themes will be impact of federal changes on Apple Health for immigrants and refugees. And we have a great speaker for that. First, I want to provide a quick information about the State Refugee Advisory Council. The Refugee Advisory Council Board is composed of 12 members, 2 to 3 from each area of refugee resettlement in Washington State. Areas of refugee resettlement are King County, Spokane County, Snohomish County, Benton-Franklin counties, Pierce County, and Clark County. The mission of the State Refugee Advisory Council is to advocate, collaborate, and build on issues that broadly affect refugee communities in Washington State. Advocate on behalf of and raise awareness regarding the needs and concerns of refugees. Collaborate across state agencies, the legislators, and disciplines on issues relevant to refugees and immigrants. Build and make recommendations on state refugee policies and programs by identifying gaps in services as well as best practices. Before we go to our next item on the agenda, on behalf of our Refugee Advisory Council, I want to take this moment to express our appreciation to Soon Man, our awesome ROC member from Pierce County. Soon served 4 years as Refugee Advisory Council member, and her last day with RAC will be at the end of November of this year. Soon's contribution to the Refugee Advisory Council and the refugee and immigrant communities have been really generous and impactful, and we'll miss her. Soon also will be retiring from at the end of September this month from Tacoma, Pierce County Health Department as tuberculosis refugee and immigrant health program manager after 31 years of services with that department. Dear Soon, thank you so much for everything you did to support the community. And I want to invite everyone to join me with recognizing Soon's great work and sharing your appreciation in the chat or with your favorite emojis. Thank you so much, Soon. And today she's also going to be monitoring our chat and Q&A, catching your questions. So thank you so much for your attention.
Thank you, Galina, for your kind words and congratulations. Thank you, everyone.
All right, now it's time to hear updates from Sarah Peterson, Director of Office of Refugee and Immigrant Assistance, Washington State Refugee Coordinator with Department of Social and Health Services. Welcome, Sarah.
Thank you so much, Galina, and thank you to all of our Statewide Refugee Advisory Council members and all of today's attendees. I just want to confirm that you can see my slides and hear me okay. Yes. Galina, can you hear? Okay, yes. Great. Oh, all right. Please let me know if you cannot hear me or cannot see. Okay. Thank you. I'm sorry, my Zoom stopped for a moment, so I'm going to go ahead and reshare my screen. Thank you for your patience.
Yeah, we see it. Yeah.
Excellent. It is an honor to be here with all of you today. And, you know, as the Statewide or the State Refugee Coordinator. I am really honored and privileged to serve in this role and to be part of such an amazing group. And I just really want to echo our congratulations to Soon. It has been an honor to serve with you and to work with you over the past 4 years, and your dedication to welcoming refugees and helping make sure they have access to healthcare and a quality life is really, really critical for Washington. So you will be missed. And I think that's, oh, go ahead. Thank you, Sun.
Thank you.
That's a great way to continue to start our Refugee Advisory Council public forum. Welcoming refugees takes a collective effort. If I understand correctly from our administrative coordinator, more than 450 people signed up today to attend our virtual public forum. And I think more than 200 people are with us today. And I think that that is an amazing amount of interest, and it really reflects how many people it takes to make Washington a welcoming community. The Washington Office of Refugee and Immigrant Assistance invests federal and state funding into our local communities to provide services that help refugees, humanitarian immigrants, and many other newcomers to achieve economic stability and long-term integration. We partner with more than 100 different organizations that are varied, from refugee resettlement agencies, nonprofit organizations, public health departments, and many, many others. Our office has a mandate to coordinate the efforts to support the social and economic integration of refugees and immigrants arriving in Washington. We do this by leading the administration of the state plan for refugee resettlement, by providing services in accordance with federal and state resources and laws. And we also help to administer services for people who may not qualify for those programs and services. So today I want to talk a little bit about changes to the U.S. Refugee Resettlement Program, how they impact Washington State, and then updates on federal legislation as well. There is no secret that today's world is very fraught with violence and persecution. And at the end of 2024, the United Nations High Commission for Refugees, they did their statistics and released information indicating that 123 million people nationwide or worldwide have been forcibly displaced. And this includes 31 million refugees, or people who've been forced to flee their home country due to a well-founded fear of persecution based on someone's race, religion, nationality, membership in a social group, or political opinion. There are also 8.4 million asylum seekers and many other people who are internally displaced. The United Nations partners with the United States government, and the United States of America was the world's largest recipient of new individual applications for people seeking refuge in the United States. And we at the in the federal government in the United States, our U.S. Refugee Resettlement Program dates back to the Refugee Act of 1980. And it is established in 2 core U.S. departments. The U.S. Department of State, under the Bureau of Population, Refugees, and Migration, administers the U.S. Refugee Admissions Program. By partnering with international organizations and the U.S. Department of Homeland Security, they conduct overseas processing to identify all of the people who are eligible for refugee resettlement. And historically, they have implemented the U.S. Reception and Placement Program in collaboration with refugee resettlement agencies that welcome people locally. They also partner with the Department of Health and Human Services Office of Refugee Resettlement. The U.S. Refugee Resettlement Assistance Program and ORR invests or partners with states, national resettlement agencies, and local community organizations to really provide a broad array of services into local communities, including refugee cash assistance, medical assistance, domestic medical screenings, as well as many other programs. We receive our funding for continued services through the U.S. Office of Refugee Resettlement. So what has changed? Since January 20th, 2025, there has been significant changes to the U.S. refugee program. On January 20th, President Trump signed Executive Order 14163, realigning the U.S. refugee admissions program. This executive order has put an indefinite pause on all refugee arrivals. There have been more than 100,000 refugees that have been vetted, referred to the United States through the UNHCR, screened, and they are approved for refugee resettlement, and they are pending. There is current litigation in Pasito versus Trump that continues to move through the federal courts. However, it hasn't changed the predicament that the current U.S. refugee program is on pause. The executive order reevaluating and realigning U.S. foreign aid also implicated federal funding that goes to support all of our overseas work to help through the U.S. refugee admissions program. And it indicated a stop work order for the cooperative agreement for the reception and placement program. And that the RMP program has been extended through December 31st of 2025. However, as a result of this and other changes that the federal government has administered, 2 of the 10 national resettlement agencies have withdrawn from the program. And this is a very significant fact because many of these organizations have long histories of welcoming refugees and immigrants. So the United States Conference with Catholic Bishops withdrew, as well as Episcopal Migration Ministries. As a result of this, Washington State actually did have one resettlement agency that was connected or affiliated with Episcopal Migration Ministries, and they are no longer participating in the reception and placement program. Executive Order 14204, addressing egregious actions of the Republic of South Africa, is the executive order that is currently allowing the federal government to welcome refugees from South Africa. And as of the end of August, I think there were fewer than 100 people resettled. However, our partners at the Department of State have indicated that they will continue to welcome Afrikaners through the program in September, and also that is the significant group of people that they're hoping to welcome in 2026, which begins October 1st. So in a normal situation, we would be receiving the presidential determination on refugee admissions, and the administration would be consulting with Congress on the numbers of people that they want to welcome. And so currently there is no presidential determination. And as of in federal fiscal year 2024, for the first time since the mid-90s, the United States resettled over 100,000 refugees. And we are anxious to see how many people may come in FY26, and if the pause is removed from the refugee admissions program. So how does this impact Washington State? Between October 1st, 2024 and January 20th, 2025, Washington's refugee resettlement programs welcomed over 2,259 refugees, as well as Afghan special immigrants. And so these are individuals who had previously arrived that we will continue to serve. In addition, there are Afghan special immigrants that are able to travel independently and have continued to arrive after January 20th. We estimate that between October 2024 and June of 2025, Washington welcomed over 4,200 newly arrived refugees, and that includes people who qualify for federal refugee programs and services. When we talk about refugees, we are specifically talking about people who come through the U.S. Refugee Admissions Program, and we also include others that are eligible for federal refugee programs, such as people who've been granted asylum, Cuban Haitian entrants, Amerasians, victims of human trafficking, Afghan and Iraqi special immigrants, Afghan and Ukrainian humanitarian parolees. And in the previous 5 years, Washington State has served unprecedented numbers of all our federally eligible refugees and humanitarian entrants. In 2023, Washington State welcomed over 14,000 newcomers, and last year it was over 12,000. So while 2025 is definitely a significant reduction from recent years, it is also an indication that we have continued work to do. We have welcomed over 30,000 Ukrainians in the past, since January 2022 through July of 2025. And many of these individuals are continuing to be eligible for our services that we are able to help people with. Last year, Washington State served over 28,000 newcomers through all of our programs because people can continue to receive services for up to 5 years. So while there are significant changes, we know here that refugee resettlement happens at the local level, and we have a lot of work to do. I want to talk a little bit about our updates on national legislation. Many of you are probably aware that in July, House Resolution number 1, also known as One Big Beautiful Bill, was signed into law by President Trump. This legislation significantly changes many public assistance programs, including federally funded food assistance or the Supplemental Nutrition Assistance Program and Medicaid, as well as many other healthcare programs. So for refugees and humanitarian entrants, it changes the eligibility for federal food assistance and federal Medicaid. It also establishes immigration fees for specific applications or benefits, specifically if somebody is applying for asylum, temporary protective status, humanitarian parole, or applying for work authorizations. And many of these applications were previously free. So for example, a family today that is applying for asylum will have to submit an initial application fee of approximately $100 per person in the application, and that is an annual fee. If that family wants to apply for work authorization, they will have to pay more than $500 to get a work authorization permit. There's also increased funding for immigration enforcement and increased in enhanced screening requirements for unaccompanied immigrant kids. So many of you are here to hear from our amazing guest speaker, Dr. Teresa Fotinos, the director of Medicaid. And we are very grateful that she's happy she's going to walk through with us all of the changes that are happening in Washington's Apple Health program. We also wanted to kind of just share with you our interpretation of what is happening at the federal level. And so federal, we have federal food, medical, and cash assistance programs. And based on the changes in HR 1, refugees will, effective July 4th, 2025, will no longer be eligible for federal food assistance. And that includes people who've been granted asylum, certified victims of human trafficking, and humanitarian parolees. However, Amerasians, Cuban Haitian entrants, special immigrant visa holders, federally qualified green card holders or lawful permanent residents and people residing under COFA do continue to remain eligible. Effective October 1st, 2026, refugees, asylees, certified victims of trafficking, and humanitarian parolees also lose their eligibility for Medicaid. What is the state doing about this? Well, I can speak for the Department of Social and Health Services, and my interpretation of what HCA is doing as well is we are all being proactive and actively working with the governor's office, our legislature, to really understand what the impacts will be. Washington estimates that approximately 33,000 refugees and humanitarian entrants may be affected by these changes. Washington State is very fortunate in that we do have state-funded cash assistance and food assistance and medical assistance programs. And so it is, we are currently better understanding the ability for refugees and humanitarian entrants to continue to be able to receive state-funded food assistance and other programs as well. So as of today, DSHS has not yet made any changes to existing SNAP eligibility requirements. This means that people can continue to go to our public benefits offices, our community services offices, our call center, and request the assistance that they need to meet their basic needs. We will share with you the links in the chat for the Healthcare Authority, DSHS, and the Office of Financial Management to share a little bit more about what all of this means. We know that there are lots of questions and there are lots of changes. There are significant impacts from the Department of Homeland Security on our humanitarian parolees. Our Cuban and Haitian and Nicaraguan and Venezuelan entrants have had, significant changes. People are losing work authorization. Then there is also the increased immigration enforcement, which is creating fear and concerns in our communities. And our Washington's refugee and immigrant communities are significantly affected and impacted by all of these changes. We are here to stand with you and to support the community as well as all of our community partners. So I just want to take this last moment to thank you for all that you do to make Washington a welcoming place. We have to do this together and we are stronger together. So thank you so much for all that you do.
Thank you so much, Sarah. We're always looking forward to your updates because there's important information we know behind all these numbers. That's real life stories and the steps towards opportunities, safety, and these slides really encouraging just to show that Washington State is remaining be welcoming refugees and supporting our new neighbors. So thank you so much. There are a few questions in the Q&A. I'm not sure if we want to address now or a bit later.
Sarah, we have 4. So you think that you can respond to these questions before we move on, or?
Do we have time, Hamed, on the agenda? I'm happy to take one or two of them.
5 minutes more, Sarah. We are flexible.
Okay, great. So San Juanito Flores asks, so when you have all the services that are domestic, they are more for refugees by definition, or does it apply to immigrants by definition? That's a great question. And I think it really depends. And so we have state funding that does help our Washington Migrant and Asylum Seeker Support Project, as well as provide assistance for employment and training through our FAP E&T program, our ARIA BFIT program, as well as our LEP Pathway program. And so I think that there are a variety of services that focus on refugees, humanitarian entrants, and then people who are low income that need their basic needs met. So thank you for that question. I'm going to answer on Omar's question. Is the Welcome Corps still active? No, no resettlement has happened. All resettlement is currently on pause, including those that were going to happen through the Welcome Corps private sponsorship program. Many of those organizations, like Community Sponsor Hub, have turned to start working with Afghan special immigrants, and they are partnering with organizations like No One Left Behind and our local resettlement agencies to help welcome Afghans. And so the work continues, but Welcome Corps is currently closed. Tristan Hall asks, have there been any refugee or asylee specific cuts to childcare benefits? I don't know the answer to that question. I'm going to ask my team to document that, and we will answer that one later. And then another question is, do state-funded food assistance programs cover the full amount of refugees prior to the cut in federally funding? So in Washington State, our food assistance program for legal immigrants is intended to help lawful permanent residents who have not been here for 5 years, as well as humanitarian parolees, asylum seekers, and others who don't qualify for federal food assistance. It is intended to be a parallel program, and so currently it matches all of the specific requirements as well as the amounts. So in the event that we are able to make the change from federal food assistance to state-funded food assistance, it would cover the full amount, is my understanding. However, I also understand that there are lots of other changes happening to SNAP, and so I would definitely pay attention, and we will share more information as we can't. What is true today may change as we begin to implement and understand the differences in our programs. All right. Yeah, I wonder, I think we're at 10:30 now. Do you want me to continue to answer questions, or I can answer more questions in the chat as well?
Yeah, maybe you continue answering in writing, just put your answer that, and we all understand that some answer will need to kind of take some more time for further research to be accurate addressing each request. So thank you so much, Sarah. Again, we appreciate all the great information that you're providing and all your answers. And now it's time to welcome Dr. Sharisa Fortinos, State Medicaid and Behavioral Health Medical Director at the Healthcare Authority, to talk about the impact of federal changes on Apple Health and immigrants and refugees. Dr. Fortinos is a family physician who specializes in addiction medicine. She leads Healthcare Authority's Apple Health Medicaid Administration, overseeing the Medicaid Customer Service Division and Medicaid Programs Division. Her team ensures that Apple Health providers provide high-quality, cost-effective care to over 2 million clients while meeting federal requirements. In addition to her leadership in Medicaid, Dr. Fortinos also serves as HCA's Deputy Chief Medical Officer. So welcome, Dr. Fortinos. Stage is yours. Thank you for joining us.
Thank you. Thank you for the opportunity and the introduction and welcome. I'm going to share my slides here and let me know when you can see that. Oh, here we go. Let's see. All right, let me flip it to slide mode. Please let me know. My windows are many here. I just want to make sure. Are you seeing the full-blown slide presentation, or are you seeing slides on the left as well?
We do see slides on the left panel.
Okay, let me try again. For some reason, all right, there we go. How's that?
Oh, then we see on the right panel, next slide, and notes.
Okay, let me try this. Apologies, everyone. Let's do this. All right, going to adjust one more time. Apologies.
No worries.
I seemingly every Zoom is a little bit different. You should not be seeing anything now, correct?
That's right.
Okay. Let us try one more time here. I want to show the screen. And let's try this.
Yes.
Okay. Let me get, oh, beautiful. Okay. Sorry for that little mess up there. So thank you for the opportunity again. I just want to start by saying every time that I hear descriptions of many of the changes that have occurred since January, I am struck by a number of things, but one of the things I'm most struck about is the language that is being used in a lot of these executive orders and rules and announcements, and that it is so cruel and dehumanizing. And I want to echo Sarah's comments in that I feel very privileged to live and work in Washington, a state where kindness and compassion remain paramount and drive decisions, and that people choose to work together and support each other. And I think that's really important. And I think that as we at the Healthcare Authority respond not just to the changes in HR 1, but really sometimes daily and weekly requests or demands from the federal government, it really is that we lead with those principles in mind. Really, our work is to help support people in the way that they can thrive and be healthy. And so it's with that our work moves forward, and we continue to prioritize people first and their health and well-being. So again, in July, Congress passed a continuing resolution for the federal budget that the president signed on July 4th. There are many provisions that impact Medicaid, food assistance, and the individual health marketplace. I'm not going to talk a lot about the marketplace. If there are some specific questions, I can try to answer them. And that this will have the potential to impact hundreds of thousands of Medicaid eligible residents. And we'll get into a little bit more detail as to why that is. And also, as Sarah mentioned, we're working closely with the Department of Social and Health Services to really understand not just what all these changes mean, but how can we work together, share our IT systems, share our staff resources, share our best thinking to, at the end of the day, implement these changes, but make the burden on people trying to understand, access, and find information about their services as low barrier and seamless as possible. So there are daily meetings about what we need to do, but also how can we work together to make sure that we make things as seamless and least burdensome for people. This is a list of the different changes that were put into place by HR 1. And in the following slides, I'll go through them in a little bit more detail. But you can see there are many, including changes to the way services specifically in Washington for Planned Parenthood are paid for, funding for non-citizens and eligibility for Medicaid, work requirements. There is some rural health funding. I just want to underscore that even though the number sounds really large, it doesn't come close to filling the gaps and needs in our rural healthcare system in Washington or nationally. There are increases in how often people will need to re-enroll or reapply for Medicaid, limits to retroactive coverage, limitations on some of the ways in which hospitals and specialty providers were able to get additional funds to support taking care of Medicaid clients. Medicaid rates are generally lower, are pretty much always lower than Medicare and certainly lower than commercial rates. So these sort of financing supports helped hospitals and providers who saw large Medicaid populations make up for some of those lower rates. Changes to that. There will be cost sharing requirements, some changes to address verification, and then more specific to our agency, increased penalties for making mistakes on implementing all of these. So how many people do we think this will impact? The work requirements and the frequency of redeterminations, as well as some of the other changes, this number, I would not take this number away, that between 200 and 320,000 Washingtonians are projected to lose Medicaid coverage. This is a guess by one entity. There are many different think tanks across the country who have put in a variety of sort of estimates. Is it 100,000? Is it 400,000? We don't know. Our goal at the Healthcare Authority is to limit as much as possible the number of people who lose Medicaid coverage. The reasoning, well, there's no reason. The way in which people will lose coverage is both because they're no longer eligible, and two, these changes are going to put in massive barriers for people to enroll in Medicaid and stay enrolled. So these estimates come from people just saying, this is too hard, this is too confusing, I can't do it, I don't understand it, so I'll just not worry about it. And so these losses are due really to making it too hard for people to get the services that they by law are entitled to. So again, this number, it's out there, but I wouldn't put a ton of stock in it. We will, with some of these changes, the state be projected to lose billions of dollars in federal funding over the 10-year period, starting next month, October, through 2034. So the state will have less federal money to support the Medicaid program. Because Medicaid is a federal state partnership, if people stop being eligible for Medicaid in Washington, the state doesn't spend that money, but we get less federal dollars. And on average in Washington, we get about 65 cents on the dollar across all of our Medicaid programs from the feds. So there will be a loss of coverage, we don't know how many, and a loss of federal funding with these changes. This slide just talks about the prohibition of Medicaid being used to pay for prohibitive providers who provide family planning or reproductive health services and who provide abortion services. In Washington state, this applies to Planned Parenthood. Initially, this law was prevented from going live, as it were, on July 4th. There were some court injunctions. However, last week, the U.S. District Court, the First District Court, said, no, this prohibition goes into effect. Planned Parenthood cannot bill Medicaid as it continues to wind its way probably up to the Supreme Court. In Washington, Planned Parenthood gets about $11 million from the federal government for the Medicaid services they provide. Governor Ferguson has committed to backfilling Planned Parenthood. So the takeaway here is people on Apple Health coverage can and should continue to seek care at Planned Parenthood. Planned Parenthood will get paid the money for those services, and we at the Healthcare Authority will assure that we don't run afoul of any of the requirements from the federal government for this happening. So again, message, go to Planned Parenthood if that's where your provider is, if that's where you need care, and your experience should be seamless if you're an Apple Health client. Sarah mentioned this, but come October of next year, There is a reduction in or people who are currently eligible as qualified non-citizens for Medicaid benefits will no longer be. And again, we anticipate that will impact about 30,000 people currently enrolled in Apple Health who will no longer be eligible for Apple Health Medicaid. They will be eligible for other programs, which currently include Apple Health Expansion, waiver coverage on the exchange, emergency medical, pregnancy or after pregnancy care, and children will still be eligible for CHIP services. So it will largely impact adults adults primarily. By December of 2026, states are required to implement work requirements. This will apply to adults in the expansion population who are 19 up to 65 who receive full Medicaid coverage. And this requirement requires that people work 80 hours per month or engage in community volunteer activities or attend school half-time. There are a number of exemptions related to this. And I have a slide upcoming that will list some of those exemptions. I think some things to point out here is that over 50% of people currently on Apple Health Medicaid already work, or they're the dependents of people who are working. So this is it's intended to get people who, in some people's estimate, aren't working and just taking advantage of the system, but most of the people are already working. In Washington, there are about 620,000 people who are covered through the expansion or ACA coverage. And so that's the number of people of that bucket who could potentially be at risk of losing or delaying coverage if they fall off because of the red tape required for proving that they're working. When we sort of dig into this, we think that maybe that'll be around 187,000 people who could lose Medicaid coverage. And this is because right now there are a subset of folks who have Apple Health coverage who they may not have phones. They may not have the ability to log on to the computer, or they are challenged to get to a community service office. And they may need some additional support in managing the application of their benefits. And so that's the subset of folks that we're concerned about may lose coverage to some of these requirements. There are also a lot of unknowns. We don't know if folks just saying they work is enough. Will we have to check every income source? What about people who are seasonal workers? What about people who are farmers and they take their crop to market once a year? What about people who work in restaurants and have intermittent tip income? There are a lot of questions. We don't have much guidance from the federal government yet. We're hoping by the end of the year to have a little bit more information about how do people show that this happens. Will people need to submit a doctor's note to say, look, I need an exemption? That makes no sense. Our goal at the Healthcare Authority is to make as much of this automatic and automated so that people tell us who they are, say, yes, they're working, and we do as much of the work on the back end as we can and minimize the burden on folks. So that is our North Star. Those are the conversations we're in with our partners at DSHS and the Health Benefit Exchange, who is where people on MAGI coverage or expansion coverage enter in to get their benefits and enroll. There is an option to apply for a waiver to say to CMS, look, we're not going to be ready to do this by next January. Here are the things we're doing to show that we're on track. CMS has made pretty clear they aren't really going to be interested in those waivers and really aren't thinking they're going to grant any. And they've said that at several national meetings. So we will still probably ask for one because we have another massive project we're in the middle of, but also thinking that may not matter that we ask. Here are some of the people who are exempt from the work requirements. Those who are pregnant or receiving postpartum coverage. I mentioned those under 19 youth, or those former foster youth, American Indian Alaskan Alaskan Native tribal members. Medically frail, we are hoping that we are allowed as a state to define what medically frail means. That's a very big topic. As a doctor, I can think of hundreds of diagnoses that would fit in there. We don't know how that will be interpreted. Disabled veterans, those on Medicare, and those already complying with work requirements through TANF or SNAP. Parents or caregivers of a dependent child or an individual with a disability, and those who are recently released from incarceration. Again, not a lot of details here for some of these, and we're hoping to get more information, being that it takes a long time and a lot of people and a lot of IT resources to make these kind of changes. So the sooner we know, the better. I am a little bit, I feel a little bit better thinking about this, knowing that my peers in pretty much every other state, but maybe two, they are also having to figure this out. And it's going to cost tens of millions of dollars to make these changes. Every state has budget challenges right now. No one's going to be ready. No one's going to be on time. No one knows the answers to these questions. So I do take some solace in the fact that we will not be the only state to be challenged to do this on time. Pretty much every state will be challenged to meet these requirements. The other piece is the change from adults having to enroll once a year to every 6 months. And again, that's that 620,000 people who will have to enroll every 6 months. And like I mentioned, there's a subset of folks who, for a variety of reasons, that's just harder to do. And so we're concerned, we're concerned about that group of folks, needing extra support and how we do that. And that will require, again, more staff across all of our agencies to help provide that support. And in a time of state budget challenges like we are, trying to figure out how to meet these new requirements with all the extra people it will take to be on time is our conversations we're in often. I mentioned the other piece about the state-directed payments and provider taxes. These are ways in which we can, as a state, both sort of have taxes on providers to sort of take up what the state would normally pay as the part of Medicaid, and then that can be matched with federal dollars. This bill says you can only do that to a certain point. You can't tax above 3.5%. If you do, we're going to decrease those tax rates down. That doesn't start till 2028. That won't be a huge significant change for the state. We have not used this broadly as some states have. We do have these state-directed payments, which is a different way to leverage federal funding without using as much state funding. And it's basically, they're saying you can have these state-directed payments, but you can't pay people above Medicare rates. A lot of states, in order to encourage providers or to make up some of those funding gaps from high Medicaid populations, they've made these state-directed payments at commercial rates. And this bill says, no, can't do that. You can only maximize that rate at Medicare. And if you have rates higher than Medicare, starting in 2028, you have to start decreasing them by 10% till you get to Medicare. And so that will be a significant hit on Washington. About $1.3 billion a year we leverage from federal funding to support some of these activities in hospitals. And that again starts in 2020. And some of the ways in which we use these funds are safety net rural hospitals, emergency transportation, primary care enhancements, behavioral health, maternity services, skilled nursing facilities, and home health. So Some of these, and there are certain groups that are excluded. So this will largely impact hospitals, essentially, the way we use these payments right now. Cost sharing requirements start in October of 2028, and this again is for expansion population and requires adults to pay up to $35 for many services. And the idea is, well, if people can't afford their copays to go to services, they just won't get care. That saves money. There are exceptions for this. Primary care is accepted. We're not focused on this right now. It's 2 years out. We will figure out a way to make this as minimally impactful to people. And so we are not focusing on this right now because some of these other timelines are much closer at hand. This is just really saying that HCA, if you don't figure out and enroll the right people and you mess up, we're going to take back money and charge you. Right now, our error rate of improperly enrolling people is 0.8%. But when you add all these changes, it will likely go up. They're saying if your error rate is above 3%, we're gonna take back money. Interestingly, the national error rate, I want to say I read, was 3.8%. So they have sort of stated that this is a huge problem when it's pretty close to their target. So anyway, this will be on us to really assure that we get all of these changes right, because if we don't do this, we will be penalized. The other piece that they did is, in the past, if for instance we had a massive IT shutdown and our error rate was higher, we would talk with CMS and say, look, our IT systems got hacked, right? They went down for a month. We messed up, right? But they're fixed. We're going to get back to normal. They'd be like, yeah, that's fine, no problem. CMS can no longer give any grace. That ability is gone. We don't care why you mess up, you pay us. And that's also a change in this bill. Oh yes, I was a little off. It's 3.31%. And so again, this is meant to save money for the federal government for collecting error rate payments. These are some slides from DSHS. Right now, there are about 2,200 non-citizens who get home and community-based supports, and 50 who receive long-term services. They will lose their eligibility, and those in residential settings may lose their housing because they don't have these supports anymore. And so those in long-term care settings will kind of be stuck. If they can't have home services to keep them in the home and they can't stay in their setting, how do they go? Also concerned about people who will still be eligible for Medicaid, but if they're in a long-term care setting and they have to do renewals every 6 months, how do we help support that so they don't lose their coverage? So again, the need to really focus on who's most at risk from losing coverage with these new changes, and how do we help identify and then support them so they don't. The other piece is there is a retroactive period that you used to be eligible for when you enrolled in Medicaid that was 3 months. That changes to 1 month. And so again, for folks who are transitioning from Medicaid to Medicare, we've really got to help support them so they don't have a coverage gap and then end up with bills with this retroactive coverage change. Or actually Medicare to Medicaid, because Medicaid funds long-term care. So I misspoke, but really, the onus will be on us to figure out how to support folks with all these changes. This, again, really high-level SNAP changes. About 11% of folks in Washington receive SNAP benefits, just shy of 1 million people. It averages around $6 per day. Eligibility is tied to school lunch programs. Most of the people who are receiving SNAP benefits, someone in that household works. The changes in SNAP add work requirements for people who are 55 to 65, so they upped the age range of expected working. And they also eliminated homelessness, veteran status, and those aging out of foster care as being exempt from work requirements. And they are focusing on keeping error rates at or below 6%, or the state will need to cover additional cost sharing starting in 2028. And these rules went into effect July 4. So DSHS is already trying to figure out how to move these pieces forward with this recent legislation. There is a rural health grant that allocates $10 billion annually to states from 2026 to 2030. The idea is the funding that comes to states will be used to support rural health transformation projects with a focus on promoting care, supporting providers, technology investment, and supporting rural communities. The application was released, I believe, last week. It's 100 and some pages. It's due November 5th. We are working closely with DSHS and the Department of Health. Our agency's been having a lot of listening sessions to get ideas for how do we put in a proposal what the state needs to support our rural communities. And so I believe the deadline for those submissions is today or tomorrow. We'll be working to develop a plan with our other agencies and then sharing that with folks once there's a plan in place. And really, this is having a massive grant like this due in 6 weeks is pretty unheard of, but it is what the law says. And CMS will be awarding states, will be telling states what their award is by December 31st. There are 2 rounds of this funding. It sounds that every state, if they submit a completed application, will get that first round of funding or half of this. $100 million. And then the second round is more discretionary. So we're hoping that we will be a recipient of these funds, at least the first round. So more to come on that, but this is active work that has a timeline coming up pretty soon. And then I did other Medicaid provisions. I did mention the refugee asylee changes. Sarah outlined what groups that pertains to. There is a reduction in the home equity limit for long-term care eligibility that starts in 2028. I mentioned the shortened retroactive eligibility coverage. And for Apple Health adults, it'll be 2 months for all other Medicaid applicants, and that starts in 2027. And then some changes to address verification processes. I think the other thing, just to make this group aware of, I mentioned that we will be submitting a waiver to ask for an extension on the work requirements. We are currently under a corrective action plan with CMS because we need to move all of our classic Medicaid renewals into an automated format. Like we do with our expansion renewals. And so we're in the process of doing that, and those renewals will come through Health Plan Finder, just like MAGI or expansion population renewals were. And so that's a massive IT build. And so we are working on that, and we have to be in compliance with that by June of 2027. If we don't, the fines are extremely significant, $100,000 a day. So this is a multi-year piece of work that we have a deadline for. And so we'll be reminding CMS, you told us to do this, and now you're asking us to do this. Can we get a little extra time? And we'll see what they say. But we do have a competing priority here that we do have a deadline for. So we are working hard to figure out how we can do all of these things at once. And I'm going to stop there and stop sharing and make myself available for questions if there's time.
Perfect. Thank you so much, Dr. Fortinos. For sure, there's a lot of important information, changes, details, concerns, and I'm sure many of us will need to circle back and reread the slides to understand everything and just kind of go back and read the sentence again. But this is so great that you were able to share this information with us today. We do have about 15 minutes for questions. So I'll pass it to Soon to monitor our chat, Q&A, live questions, if someone will raise a hand and want to clarify something out of the information. Thank you so much.
Thank you, Galina. Yes, Dr. Fortinos, there are 3 questions on the Q&A right now. And so the first one, Sarah is trying to answer that. So another one is, if refugee lose coverage by October 2026, how will new arrival will still be eligible for refugee health screening?
Sarah, do you want to take that one?
Yeah, actually, soon I'm gonna invite Jasmine Matheson, our state refugee health coordinator, to join us to answer that question as well. So thank you, and thank you so much, Dr. Fortinos, for your amazing presentation. Over to you, Jasmine.
Yeah, happy to help with this question. So for refugees and other folks who are eligible for the specific refugee health screening exam, they do have potentially access to a different program called Refugee Medical Assistance. That's a health insurance program. It is only for 4 months after the date of eligibility, and I can drop a link in the chat with more details there. So it is a limited time coverage, but it would include the period where people would usually get refugee health screening.
Right. Thank you, Jasmine. All right. So the next one, okay, so that's a comment. Hello, Sarah. I'm going down the list. I work with logo. It's not
Hey,
available.
soon. Just
Yes.
a recommendation. There are 2 people in the attendees that have their hands raised. I
Oh,
wonder if
okay.
we want to invite them. And
Okay.
Hamid, I don't know if you have to allow them to open their call, but I see Christina Mendoza and Chris Ann both have their hands
Right.
raised.
Okay. I was focusing on the Q&A. Sorry.
Yeah, Sarah, they should be able to unmute themselves. I left it open and speak. Let me go. Allow to talk. Okay, Christian, I let you in.
I'm sorry, was there a question? I was having a hard time hearing if there was. I'm sorry.
While we were waiting for somebody to join, I'm going to ask Amber Duke's question. So Amber asks, do we know people will still be eligible, if people will still be eligible for Medicaid if they are ineligible for work? I think she's specifically talking about people who are not work authorized, but I wonder if this is a question if they'll even be eligible for Medicaid if their immigration status doesn't allow for a law, the ability to work. So I don't know if you have thoughts around that one, Dr. Fortinos.
Yeah, I think, as I think through all of these iterations and rules, they're extraordinarily complex, and I am learning every day the difference between qualified, non-qualified, all the different types of ways in which people come into the country. I think the first question is, is in order to be eligible for Medicaid, you have to meet the income requirements and the citizenship or lawfully present requirements. And so that's sort of the first screening. And so if you're not eligible to meet the work requirements, then you're likely not going to be in that group of sort of qualified folks who would then be eligible for Medicaid. I think important things to take away is that people who are pregnant will still have eligibility for Medicaid coverage. children will still be eligible for Medicaid coverage. And people who need to seek emergency care, and that includes dialysis, and right now cancer care, will be eligible for, it's a horrible name, but alien emergency medical or emergency medical. That is in a separate law that this didn't touch. So those, and again, that's not health care, but it's sort of stopgap for emergencies. So folks will remain eligible for those things, whether or not they're eligible for Medicaid. There may be some changes in the future to the emergency medical cancer care. There aren't any rules yet that tell us that's not allowable, but we're concerned and want to keep watching that. So folks will still be eligible, some groups will still be eligible for some things. Newcomer underage. Again, children will still be eligible for Medicaid coverage under CHIP. So kids will still be covered. 18 or younger. And we are happy, I see the question about giving this presentation in other places. We are happy to be able to provide this information broadly, because the more people understand what's changing and how it's changing, hopefully that will empower them to be, one, more knowledgeable, and two, able to support those who may not have access to the kind of forums that this is or know any about this. I will say I have a brother who lives in Colorado, and he has some significant health issues, and he's on SSI, and gets Medicare, and I was trying to help him apply for Medicaid and food benefits in another state. And I have several degrees, and it was a pretty easy website, but even that, it's taken, with him on the other end reading everything to me, it's taken us hours to walk through the application. And he doesn't have any cognitive deficits. And so the two of us, it's taking hours to work on a pretty simple website. This stuff is ridiculously and unnecessarily hard, but it is what it is. So I do think that the more we can help folks, the better. The AEM program, that is currently is what it is. There are conversations that will happen, I suspect, with the supplemental budget that's coming up. And as far as future changes, really not aware of any significant ones, and any changes will be directed by the governor or the legislature, given that will become with them. Individuals with disabilities, no, there will be exclusions for disabilities. We need more detail on what defines a disability in the language. That's some of the language we're waiting for from CMS. And again, that medical frailty piece, we are hoping that we are allowed to define that. However, having 50 states and 6 territories or 7 territories define that independently could create some problems. So we need more information to know exactly what that means. And then again, our hope is that people will be able to self-attest, that they'll be able to say, I have this, and we trust that, and not require them to chase down paperwork. How do these policies affect the American-born children of those? So yeah, I think the question is about what about households that have people with multiple eligibility. The children would still be eligible for their coverage under Medicaid. The adults might not, and so again, it will just require more support for those families trying to understand what their options are. So the executive order saying that English is we have no plans to change interpretation or translation services at this time. Executive orders are they're sort of announcements. basically. And once that announcement is made, whoever that announcement is directed at, whatever federal agency, they have to make rules to implement that announcement. And so we've seen no announcements about English. We also haven't seen any rules proposed by HHS, Health and Human Services. They're the agency that Centers for Medicaid and CHIP Services lives under. We've not seen any rule changes put out by them. And usually when there are rules, it's a proposed rule that there is comment for. And then often they'll sort of change it related to that. Some rules that an executive order is we don't need to put out comment periods anymore. So much of so many of these things are in some phase of litigation that we're doing the things we know we have to do, which is all the requirements in HR 1. We're planning for those, we're preparing for those, doing our best to try and meet the deadlines that we've been told, understanding if we can't do them all at once, how do we prioritize? And then for all these announcements, the executive orders, we're just waiting to see what happens next. Because they're kind of like press releases, really. Rather than you must change everything right now. So more to come.
I can read this question to you. Are Ukrainian humanitarian parolees who are over 65 and are sick, will they lose Apple Health coverage after October 1st, 2026? And do you want to go ahead and answer that question?
No, go ahead, Sarah. Yeah.
Okay. So I'll call on Jasmine as well, but my interpretation is that yes, Ukrainian humanitarian parolees will no longer qualify for federal medical service, Medicaid, and I believe that includes Medicare as well, after 10/1/26. I don't know, Jasmine, if you wanted to add anything.
I don't think I have any additions. I mean, I think that's correct from my understanding for the federally funded programs. I think that Dr. Fatinos has mentioned some of the state funded things, which may also be possibilities. And so I would really encourage anybody who is in that situation to work with their healthcare team. And I also dropped a link in the chat to Washington State's network of free navigation supports. And these are folks that are in all parts of Washington State who provide free help to figure out what people's options are for their medical and dental coverage. So definitely I would encourage people to work through the individual pieces there too.
The question, so the I don't know, it's called the West Coast Alliance, but includes Washington, California, Oregon, and now Hawaii is joined. And the focus of this group is really right now on vaccines, sort of assuring that people, the residents in our states understand what the science is behind vaccines, what recommendations are from the American Academy of Pediatrics, the American Academy of Family Physicians, the American College of Physicians, which are internal medicine doctors, really saying we're going to look at the science and we're going to make recommendations, cover and provide the vaccines that we know improve people's health and protect them. And so that's what that's about right now. It's really only about vaccines. And there are other state coalitions that are forming. There's a New England coalition that's formed and some others. The states are really figuring out how to band together and provide support and good care for their residents at this time of federal change. Yes, to clarify the question, once a refugee or parolee adjusts status and has a green card, lawfully permanent resident, they could qualify for Medicaid, Medicare. Again, that is correct. And then if they meet the work or community requirements, if they're not eligible for an exemption. Yeah. I mean, sadly, all these changes just make a ridiculously and overly complex healthcare system that much worse. I hope future generations that do this work figure out how to make our system simpler and not harder, because healthcare should be accessible to everyone and shouldn't be this hard.
Thank you so much again, Dr. Fortinos, for your genuine care. We can feel that, not just the information, and deeply appreciate that. As we all hear who's attending this forum, not the random people, all those working with refugees and immigrant communities and receiving all these questions and really thirsty to get information and clarification, not to misinform and push some misleading kind of information around in the community. So this is like a highly important to have this at least basic understanding, because we're not trying to become the expert to guide people around in every single case and detail. So we'll leave it to designated professionals to do that. And thank you so much again for making yourself available and take your time and join us today. Thank you so much. I don't see any other questions, and we're right on time to move to our next very good presenter that we already asking her questions. That's Jasmine Matheson, State Refugee Health Coordinator, Washington State Department of Health, and we'll talk about refugee health and refugee health promotion program. Thanks so much, Jasmine, and welcome.
Thanks, Galina. Can I just confirm you can see my slides okay and hear me?
Yes.
Wonderful. Well, thank you all so much for the opportunity to join the Refugee Advisory Council today. My name is Jasmine Matheson. Use she, her pronouns. I'm with Washington State Department of Health and serve as our state's refugee health coordinator. I wanted to just start by really echoing and being so grateful for the information shared by Sarah and Dr. Fortinos about the very significant changes that we are all navigating together, and how important it is to have this information as we support clients, as we walk alongside people in supporting health and wellness. There's a lot happening right now, and having access to this information as we learn about it to be able to share back is just so important. I get to talk today about our state's refugee health promotion programs, which is one of those ways that our state is able to invest in our local providers who really do support people in their health and wellness. This program is a partnership, as our health programs focused on refugees and new arrivals are, between Department of Health and Department of Social and Health Services. We are so grateful for this. This is really a collaborative effort that helps make this possible. At the Department of Health, our program with Refugee and Immigrant Health Program works to support health and wellness, and some of the key areas we do that in are through coordination of our medical screening and health promotion programs, use of data to understand health outcomes, and investment in local community health outreach work, as well as bringing together partners to share information. So some of the health milestones that we talk about when we're looking at newcomer communities are shown here. And there's a lot of different areas that people are navigating simultaneously. But for health, some of the big things initially are things like enrollment in health insurance, completing refugee medical screening for groups that are eligible for that, and really connection to primary care. So today, as we're talking about refugee health promotion programs, we're really looking at the programs and services that people are eligible for during the initial 5 years after arrival or after their date of eligibility. The refugee health promotion programs are possible through federal funding that comes to Washington State through the Office of Refugee Resettlement. ORR provides the structure and the parameters for the work that we can do using these funds. And the 3 goals are shown here, with a focus on health literacy, coordination of care, and wellness groups. I do want to note that because this is federal funding, it is only available to people who have eligibility statuses that are shown on this list, which includes refugees, people granted asylum, special immigrant visa holders from Iraq and Afghanistan, and Ukrainian humanitarian parolees. And these are eligibility categories that are set by the federal government. So here in Washington, for federal fiscal year 2026, which begins this October 1st, $7.6 million will be invested with a range of community partners. The teams from DSHS ORIA's Health and Wellness team, the ORIA Prime team, and Department of Health are all supporting the implementation of these contracts. The 3 focus areas for the work are shown in the boxes here, with health education, health and mental health navigation, and wellness groups. And the number of agencies proposing work through these different areas are shown for each. Washington prioritizes using refugee health promotion funding to invest in local community partners, and the agencies propose projects really based upon needs and strengths within their own communities. So I don't have enough time to go into all of the different examples here, but a few of them include health navigation that's focused on people who might have more complex medical needs, health education focused on a range of topics, including our really complicated U.S. healthcare system, nutrition, immunizations, child health, peer mentoring programs, which support wellness, as well as groups that are focused on youth or parents of young children or elders in order to support mental health and well-being. The 24 agencies that are part of this work are shown on this map in the black dots, and you can see that they are based within 7 different jurisdictions, which largely align with the areas of the state where we've welcomed significant numbers of refugees and other newcomers in the past few years. And this slide shows the logos for some of the agencies who are partnering as part of the refugee health promotion work this year. These agencies range from clinics to resettlement agencies, health departments, and many community-led organizations. We're so grateful for the strong and diverse network of partners with deep community-rooted experience who are going to be providing these services and really walking alongside folks to meet health and wellness needs. So to learn more about specific services in a particular area of the state, if you have clients who may be eligible, the ORIA website has an interactive resource tool. We are in the process of doing some updates with the current information for this new federal fiscal year, but the tool will provide a searchable list by county or service type, and there's also links to other types of services. And with that, I will turn it back over to Galina. I'm happy to help with any questions. Thanks so much.
Thank you, Jasmine. And I would turn it to Soon to see if there's any raised hands or questions in the Q&A or the chat, any clarifications needed. And thanks so much, Jasmine, for presenting.
Thanks, Galina. I don't see any in the Q&A, and I believe there is no raised hand at this time either. I'm looking at our chat box. There is none. And so thank you.
All right, sounds good. And again, reminding that all the slides going to be shared a bit later after the forum, so everyone will have a chance also to review this information again and follow up if any other clarifications needed. And now it's time to watch our 5-minute video slideshow to see some updates, what's happening in local counties with services. And this slideshow is kindly coordinated by Sawa Shi, a RAC member from Tri-Cities. So thank you, Sawa, for working on the slideshow, and Hamed will help us to turn it on. Thank you so much for watching. And if you have any updates on your local community services, and I'm sure you have plenty, so please share it with us. Hamed can put like a link in the chat. You can send your information to Oraya Info email, and we'll include your updates at the next forum. Again, reminding that we will be sharing all the materials, presentations, all this great information that you received today later by email. So you'll receive all these materials. Next public forum will be scheduled sometimes in December. We don't have an exact date yet, but we'll notify you, and please communicate with us by the same Oraya Info email if you'd like to follow up and got some additional questions for the presenter. We understand how important all this information is, and encouraging you to stay connected and continue your great services in the state of Washington, welcoming our new neighbors. Thank you so much. If there's any other questions that we can answer, please let us know. Soon, do we have any additional questions? If not, we can end a bit earlier, and you have 25 minutes back on your time, looks like. You can do so much with 25 minutes.
Thank you, Galina. There is none for both Q&A and chat, and I don't see any raised hand at all. So thank you.
All right, then wishing you a great rest of your day. And please let us know if there's anything else we can help with, or offer some ideas, some topics for a next forum. We understand there's a lot of changes happening, and it's important to stay in touch and stay informed.